Thanks, Dr. Thompson. Donna, if you've started talking, you are muted.
I just was going away.
Okay, so one second, because all right, yeah. At least we're all on the same wavelength.
Go back to the first slide.
Yes. So go ahead.
I have given this talk before on echo, and so I used my same slides. And when I was working on them last night, I realized that I didn't put references on them before, but I can tell you the reference that I used the most was the booklet that ACOG published probably about 10 years ago. Their chapter on conservative management in severe preeclampsia is very good. It has an excellent flow diagram, and I would suggest that you read that if you're more interested in this. Next slide. So, you know, if you're my age, the minute a severe preeclamptic walked in the door, we got ready for delivery. We may have given steroids and then delivered, but the potential benefit of keeping somebody pregnant is that, you know, we get a longer gestational age, there's less days in the NICU, and there's less fetal complications. Particularly respiratory distress and neck. Next slide. Somebody can't see the slides. Rachel.
Hi, so if that is happening, Dr. Gill, are you able to see the slides?
I am able to see them.
Okay, so it's possible if you are you participating on a phone, the individual who can't see the slides?
Okay.
Let's continue.
So the gestational age to begin, if you've got somebody less than 23 weeks, basically the chances of survival is 0. You know, there might be a case report of one person surviving, but the issue with early onset severe preeclampsia is these babies are growth restricted. Many don't weigh 500 grams at 23 weeks. And therefore, not only do you have a weight problem, you also have a gestational problem. At 23 and 0, there is a small number, about 1 in 5, that survive. And then the survival rate, as in a normal pregnancy, goes up starting at 20, goes up tremendously at 24 weeks. Next slide. So our initial maternal evaluation is, obviously, we should look at her blood pressure and her vital signs. Her urine output is, we forget about this, but urine output is very important to look at. The symptoms, whether or not they had headache, blurred vision, scotometer, right upper quadrant pain, and difficulty bleeding. Also determine if she's having contractions, abdominal pain, or bleeding. And the labs that are important to get are CBC, LFTs, and a serum creatinine. If she is contracting and I am worried about an abruption, obviously I will add fibrinogen and a PTT, and a D-dimer. Next slide. The fetal evaluation obviously should be NST with contraction monitor, amniotic fluid assessment. A lot of these babies have low fluid. And when we do fetal evaluation in the hospital, I would recommend a growth ultrasound every 2 weeks. Now, most of the time on an outpatient basis, we don't do growth ultrasounds every 2 weeks, but there's enough of a change in their weight, if there is going to be a change in their weight, that you can tell a difference in 2 weeks. And the reason why I say this is if a growth plateaus, then that's another warning sign for you. Next slide. So when the patient presents on labor and delivery, you should continue her there, observe her, obviously give steroids and magnesium, control her blood pressure with antihypertensive medication, and do the maternal and fetal evaluation as I previously stated. Next slide. So the contraindications to expectant management is eclampsia, pulmonary edema, DIC, uncontrolled severe hypertension, abnormal fetal testing, abruptio placenta, and a fetal demise. Okay, so these patients should be set up for delivery fairly quickly. Next slide. So the patients to be delivered after we get through corticosteroids are infants that are at 33 and greater than 33 and 6/7 weeks. That's 34 weeks. If they have persistent symptoms, evidence of help, growth restriction less than 5th percentile, and I'll say this is relative because occasionally if we've got a 25 weeker at the 2nd percentile, we may continue to monitor that patient. Severe oligohydramnios, reversed end-diastolic flow, labor or prom, and significant renal dysfunction. For sure, if they got a creatinine greater than 1.2. Next slide. So when you decide a patient is a candidate for expectant management, then you need to have adequate maternal and neonatal resources. Primarily, I would say you need in-house coverage, either by a laborist or by a residency program, because these patients' status can change on the weekend, in the middle of the night, and you need somebody that can evaluate the patient. This should only be done on the inpatient side. You can stop magnesium because people are always asking, when can we stop magnesium? When we decide somebody is a candidate for expectant management, we usually stop the magnesium within 24 hours. Obviously, you got to do vital signs, symptoms, and lab monitoring, and it depends on the lab, but usually every 3 days, and you can use oral antihypertensive drugs. Next slide. You should abandon expectant management, obviously, for 34 and 0/7 weeks. New onset contraindications, such as eclampsia or something like that. Worsening maternal labs, abnormal fetal testing, labor or prom, and uncontrolled hypertension on meds. Next slide. Before I talk about the mode of delivery, I would just like to say that it's very important when you're managing a patient conservatively, that in your mind, you decide what are your bailout criteria, because every time you get called with something, well, I can fix that. Well, I can do that. Her platelets have only gone down 10,000, and so what I do is I basically go through and I make myself a list. Like if they're less than 28 weeks, I will at least max out 2 antihypertensive drugs before I would consider delivery. Whereas if they're 32 weeks, I may only max out 1 drug. So in your mind, say, I'm going to deliver her for this. You can even use 3 drugs if you want to, but you have to decide, if I max out at this amount, I'm going to deliver the patient. If her creatinine goes from 0.9 to 1.2, I'm going to deliver the patient. Also, her platelets are important. Antenatal testing. If I had a baby that I've been okay with, and then I'm starting to have to do repetitive biophysical profiles because the strip is not reactive, then I consider delivery. Also, if I have to do things like IV meds, she's stable on 2, but every other day I have to do IV meds. I think people get into trouble when they continue to try to prolong pregnancy when there are even more warning signs coming around. The other question I would have is, I talked with y'all about the SFLIT and PLGF ratio last week. I can tell you, on an early onset severe preeclamptic, it is going to be bad. Okay? No doubt about it. It's going to be bad, especially the ones that have no hypertension, and this is true early onset severe preeclampsia without any other comorbidities. So I don't want to see that number. I don't want the lawyers to see that number. And so I don't order them on patients I know have early onset severe preeclampsia. Then the next question is, what is the mode of delivery? So if you are less than 28 weeks, most people get a cesarean delivery. The reason this is the case is because these babies usually are growth restricted and have elevated Dopplers. And so almost all of them get C-sections, and obviously they can be breech. Between 28 and 32 weeks, the chance of a C-section is 53 to 65%. And after 32 to 34 weeks, the risk of getting a C-section goes down significantly. So we almost always try to do a vaginal delivery after 28 weeks at 28 and 0, unless there's severe growth restriction, abnormal Dopplers, any kind of question of abnormal fetal testing, or your platelets are dropping, and you're down at a 90 now, and you're worried that if you try to induce her, you may get down where you would have to use a platelet transfusion. We would not induce a patient like that. But you can't go and find articles that tell you you should do this one way or you should do that one way based on X, Y, and Z. Most of it is based on expert opinion. So I just gave you my opinion. And so I'm happy to take any questions.